Every day starts with me. Like, what could be better than starting off with a healthy dose of epidemiology? I know there were some requests about me recording a lecture Wednesday and not having class in person, but that was not approved by the big bosses, so I'll be here at 8 o'clock. Hopefully you will be too.
I'm sorry.
Yeah, you have class at 10 as well, so yeah, so just FYI, we will be here. So any questions about the exam or anything like that? Do you guys what do you guys think about the test? Too bad? You guys felt adequately prepared for it?
It was rough.
It was rough? I thought the grades ended up pretty good for the most part. But if you have any feedback, let me know. If we want a soundtrack for the...
I'm so sorry.
That's okay. Don't worry, it's recorded for all eternity on YouTube, so that's okay. Okay, so now we're going to switch gears completely. There will be some related topics here, but we're going to be switching over to the epidemiology side of things. And so we're going to get basically 6 lectures of this. There will be a review, depending on how quickly I can get through the material, I might record that one. And then we'll do a workshop for class 7, and then there'll be the test. So it'll be very similar to what the first half of the class was like. Okay. Any questions on that? All right, you guys see the lecture was posted? I did this morning, so for the last minute posting. All right, so we're going to talk a little bit about basic epidemiologic concepts and principles here. So just get some of the definitions out of the way. Talk about a few examples of where epidemiology has come up. Before we get started, what do you guys think epidemiology is? Study diseases. Like, why do we study them?
To show the prevalence and incidence rate changes over time.
Okay. In response to what, though?
Lots of like different environmental factors
Mm-hmm.
in populations.
Yeah, so we can see how changes affect things like, we're going to find that one of the things we can try to do is learn how to prevent disease, especially. So if we can look to see what the typical causes are, we can hopefully initiate things in order to help prevent them from occurring in the first place. So cover these objectives here. I'll let you guys read those at your leisure. Talk more about those in detail. So as you mentioned, epidemiology is going to be that study of the distribution and determinants of disease in the human population. We'll talk about some examples here in just a minute. And it's a basic science and fundamental practice of public health. So one of the real kind of good clinical example that I have of epidemiology at work is working with the poison centers where I did my fellowship at. And we actually had a lot of good relationships with the Department of Health within Florida. And so one of the things that we would do at the poison centers, we would log every single call that came to us. We had a lot of calls that came in from, lay people at home saying my kid got into this, or I think I've been exposed to this, and we would collect all that data in real time. We can actually, all the poison centers report that data up to what we call the National Poisoning Data Service. And so it's real-time collection of data, and we can look for trends in things like, is there a new drug of abuse that is out there that are, people are having to go to the ER for? So you guys remember the bath salts? Yeah, anyone ever did any bath salts? Yeah, you shouldn't have done that. Yeah, it's a bad idea probably. Had you done them? But yeah, so that was one of the things that the poison centers were kind of first starting to getting the word on, because we would get calls from docs who were in the ER saying like, hey, I got this guy who's really hyperthermic and agitated, and he had he was doing this stuff called white lightning or whatever happened to be the drug of choice at the time, and so we were able to kind of collate that data. And one of the other things we did was reporting a lot of that data over to the Department of Health as well. So one of the big things you see, especially around hurricane season, when we get hit with something, is usually increases in carbon monoxide exposures. What do you guys think that is? Yeah, a lot of people running generators in their house, and only then get stolen, so they'll run them in the garage. Obviously, that produces a lot of fumes, and carbon monoxide poisoning is somewhat common with that. So again, you can look for trends and things like that. I'll show you a website probably a little bit later on in the class where you can actually look at real-time poisoning cases that are being reported in Florida. It's actually kind of a neat website, so I'll probably show that later. So an epidemiologist is going to be one of these scientists that studies disease frequencies in populations. They try to identify the risk factors for disease and hopefully try to improve the ultimate health of the population. And then the health, according to the World Health Organization, is going to be a state of complete physical, mental, and social well-being, and not merely just the absence of disease or infirmities. They're also looking at things like quality of life and how that's going to be impacting the healthfulness of a person. So epidemiology is really important with preventative medicine, where we're going to be using the application of preventative measures by clinical professionals to maintain health. You'll see that a lot of these are going to be behavioral in nature, because one, those are probably the easiest things to influence with disease, and also some of the most effective ones. And then public health just being the application of preventative medicine principles to the population and how to help prevent disease from occurring. And then when we talk about epidemics, I'm sure that term gets used pretty loosely. You hear about all kinds of epidemics all the time, but it can be restricted to one location. However, if it spreads to other countries or continents and affects a substantial number of people, that's when you can have the term pandemic being applied to an epidemic. Okay. So there are several changes that could occur in an infectious agent that may trigger an epidemic. We'll talk about some of these more details in depth, but we can see things like increased virulence, the disease strain. If you have introduction into a novel setting, so certainly introducing a new agent to where it has not been before, where it can potentially propagate. We'll look at things like changes in host susceptibility to infectious agents, and then changes in the actual exposure to the infectious agents. You guys remember when the swine flu was really big? Yeah, so that was actually, I was in rotations when that actually hit. I remember seeing a lot of cases of patients who were relatively healthy just getting hit with the flu, could not figure out what the heck was going on. We had one, I was rotating in the PICU at one point. We had a relatively healthy, although she happened to be obese, 17-year-old female who actually ended up on ECMO. You guys know what ECMO is? Basically, it's extracorporeal membrane oxygenation, where basically it's like putting someone on a perfusion pump, where we are taking the blood out of her, oxygenating it, and then putting it back into the patient, right? So it's the way, because she had complete respiratory failure, complete cardiovascular collapse due to this. So it was a very severe thing where even though she may have been, vaccinated against the flu previously, this is a completely new strain that we had not encountered before, and thus we were not very well prepared for it, right? So that's why a lot of the newer flu vaccines are going to be quadrivalent, because now they'll actually end up having a strain that will be protective against swine flu, right? So again, this is an example of kind of one of those epidemics kind of hitting. And so we know that it does not need to be necessarily contagious to be, an epidemic. Certainly, West Nile virus would be a good example, but obesity being another big one that's kind of a big buzzword nowadays. So just to give you one good example of how epidemiology has helped to curb disease, have you guys, I'm sure, are aware of cholera? You've heard of it before, right? Microbiology, probably. Yeah. So we know that it's caused by this Vibrio cholerae, that the main symptoms are going to be pretty profuse, watery diarrhea, and vomiting. And so what we were able to see, and again, back in the day, we didn't necessarily know this, that the transmission was occurring primarily by drinking water or eating food that had been contaminated. And again, for a good long time, people were not sure why this disease was spreading the way it was. We can see that the severity of the diarrhea and the vomiting can lead to rapid dehydration and electrolyte imbalances, and that's typically why the death occurs in those more severe cases. Now, usually the primary treatment is going to be oral rehydration therapy, especially if you catch it earlier, the better, because you can just rehydrate them and usually give supportive care for that. In some cases, you may need antibacterial drugs. And we see that worldwide. We see very frequent cases of it. You notice here in the U.S., we don't have it being quite as common, and it can still lead to several deaths every year. So you can see anywhere between 100 to 130,000 just in 2010. And so this is one of the earliest infections to be studied by epidemiological methods. So what they found was, in typically, if you have a person with cholera and you can treat them quickly, the mortality rate is usually less than 1%, right? So it's assuming you can kind of catch it, diagnose it, and are able to treat them with good supportive care. However, like we said back in the day when they weren't sure why things were spreading or who was getting it, if it was untreated, you saw the mortality rate was very, very high, anywhere between 50 and 60% for those patients. And then even when we see certain changes in their genetic strains of the cholera, you can end up having new epidemics starting. So like one in 2010 in Haiti, one in India, they can occur, where it would cause disease even quicker, so within 2 hours in those cases. So basically what we're seeing is that, now that we have better ways in order to determine what's causing it, we can see how it's spread, we are better able to catch it and hopefully treat it. But there's still, chances for epidemics to occur, mainly just due to changes in the virulent strain, looking at host susceptibility, those factors we already mentioned previously. So one of the big ways that we saw this spreading, because they think that it likely originated in the Indian subcontinent, and then just due to trade routes and things like that, it was able to spread to Europe and North America. And so we've seen that since 1961, that was the most recent epidemic or the pandemic. We've seen that there's been very, very many of these happening over the past 200 years. This is also going to be one of the first reportable diseases that was listed in the U.S. We'll look at a chart a little bit later in the class that talks about all the different reportable diseases. You guys remember that case I told you about with the child that came with meningococcemia? That unfortunately passed away. That is a reportable disease we reported back to the CDC because, again, if you notice that there are multiple cases of that popping up, CDC can come in and start to investigate those, right? Especially knowing that kid was at Disney or knowing there were other popular tourist attractions. That's kind of the thing you want to be able to track in those cases. But when this first kind of got its first, kind of look through the epidemiologist's eye was back in 1854. This is over in England, and we had John Snow, who's probably one of the first epidemiologists, so to speak. And he was a physician, and he was actually trying to go back and determine, what in the heck was actually causing these outbreaks of cholera, what in the world was going on with it. And so what they actually did was they started to plot out on a map specifically where these cases were occurring to try to determine what was going on. So what they ended up finding was due to contaminated water source. I'll show you a map in a second, but basically this one specific pump was infected, and so they were able to determine that based on the location of the disease incidents. So if you look here, there's a map of London, or a specific part of London, and they were basically just plotting out where the different cases of cholera were happening and kind of be able to center it back to this one specific water pump on this broad street here. And they were able to basically take out the pump, and all of a sudden, a lot of the cholera cases started to disappear. So basically cause and effect, they were able to see that, yes, this was probably the most likely cause of it in this case. Another good example of epidemiology being used to prevent disease would be in this case of childbed fever, this puerperal fever. Basically what they were seeing is that they were having these children who were being delivered in a specific hospital, and they were looking at the death rates that were occurring due to this. And this was back in the day, back before we really had any idea of the germ theory, and were able to really, people weren't necessarily washing their hands like they were supposed to because they just didn't know about it at the time. So one of the things they noticed is that at this particular delivery ward, they realized that the death due to this childbed fever was 16% mortality rate when fever, and it was substantially higher than the 2% that was happening over in this other ward where the midwives were being trained. So this one physician wanted to determine why the death rates are so much higher in these newborns as compared to this other ward. And so one of the things that he had noticed was that the physicians who were being trained in this first ward, they were actually performing autopsies every morning on women who had died the previous day, but the midwives did not have to do that as part of their training. So as you might imagine, if you're touching a bunch of dead bodies and then going straight to delivering babies, could be an issue there, right? So basically they were able to make the distinction there is that, okay, maybe there's something going on here, there's some connection, so they wanted to start looking at basically, starting new ways to cleanse in between things. You notice that the first thing that really triggered this observation was when one of the colleagues had accidentally nicked himself during the autopsy and ended up developing septicemia. Right, so it was one of those things where kind of get the idea that maybe there's some connection here and then investigate it further. So they tried a few different cleansers, and then what they actually finding was that the mortality rate ended up dropping very significantly after they started to wash their hands regularly between doing the autopsies and doing the births. Even though they saw this data that showed that yes, this was effective, it was back in the day before we knew about germs, it was still kind of looked at with a lot of skepticism and ridicule. So as you might imagine, looking at this graph, it's pretty clear the connection here. So they're looking at basically the mortality rates during this time period. Again, looks between the 1700s and 1800s. You notice here that the rates are pretty similar for the most part. And then when they started to do the autopsies, you can see where the death mortality rate started to increase pretty significantly. And then this is where they started to use a chlorine hand wash. And then notice how it drops to be pretty similar to what was happening in the other ward. It's probably even a little bit lower considering the fact that they probably had the cleanest hands at that point as compared to the midwives. So again, noticing that there's probably, you have to kind of have an inkling of, okay, what's going on here, looking for the causes, and then trying to initiate some change that will lead to prevention of disease. So this is basically all we're doing with epidemiology. Okay, so typically when we're looking at this information, usually it's going to be the study of something that is affecting a population. So we're looking kind of on the grand scale. We're going to be looking for things that we can apply to our single patients in the clinical world, but in most cases, the epidemiologist is looking more at populations. And so we want to study the factors that determine the occurrence and the distribution of the disease within that population. So you can see that there are kind of 4 levels of study. You can see at the submolecular, molecular level, this is where we can look at the immunology, the biochemistry of the disease that's occurring. We can start to look then at the tissue or the organ level. It's kind of going up in complexity, looking at the anatomic pathology. Then going into the individual patients, this is kind of where we get back to our clinical medicine, kind of where you guys will be involved in taking care of patients. And then looking at the overall populations, and epidemiology is where this kind of comes into play. So again, classical epidemiology is typically population-oriented, and so the studies would be of the community origins of the health problems, and then especially related to infectious diseases. This is where you saw a lot of these being done in the first place, but now we can look at other types of disease states, not necessarily just ones that are infectious. And then we're evaluating things like nutrition, looking at the environment, human behavior, psychologic, social, spiritual states of the population, and how this can have dramatic effects on the health of that population. And we'll look at specific examples as we go along in this class. And then the clinical epidemiology is where we're using research designs and statistical tools that are similar to those used by the classical epidemiologists. And we're studying patients that are in healthcare settings to improve prevention, early detection, diagnosis, and treatment of various disease states. So you guys remember when we did the workshop, you guys remember your article where we looked at patients who present with dizziness to the ED, right? So what were they trying to do in that study? You guys remember? You already blocked it out? Right.
Develop a model.
Yeah, so they're trying to determine who shows up with dizziness to the ED, who gets diagnosed with stroke, right? Because again, they're looking at the population that's coming into the ED with this complaint and trying to determine how can we kind of single out those patients who are most likely to be diagnosed with stroke, right? Because if you can detect that earlier, potentially you can have better outcomes for your patients by giving them whatever interventional therapy it's going to be, whether it be thrombolytics or some other intervention. So just a real-world example of where they're trying to use this clinical epidemiology. And again, in a lot of cases, you'll see that we can adjust for things like comorbid conditions and other clinical treatments in order to find true actual differences that we're causing in these populations. So infectious disease epidemiology is typically dependent a lot on laboratory support. So again, actually being able to culture out agents and things like that. And then looking at chronic disease epidemiology is where we can look at more at complex sampling and statistical methods, where we can actually look at big swaths of the population, control for different variables, and try to find specific differences between them. And so you'll see that the distinction between the two fields is kind of becoming less clear over time. And so we'll see that we're going to be able to use markers for each to be able to look at both infectious diseases and more chronic health conditions. So looking at the specific stages of disease, you guys are probably familiar with this, but first we had the pre-disease stage, where this is before the pathologic process ever begins, right? So this is going to be where early intervention may prevent exposure to the agent of the disease. So specifically, if we're looking at things like lead, trans fatty acids, microbes, we can prevent exposure to them in the first place to prevent the disease from occurring at all. And so this is where the term primary prevention comes into play. So this is preventing the disease process from starting. So as you might imagine, doing things like in hospitals when you have all these signs up about washing your hands, right? This is primary prevention because you want to be able to prevent the exposure from occurring in the first place. You prevent spread of bacterial infections in patients in the hospital, right? You guys think of any other type of primary preventions? So a vaccination would be a good way to prevent the disease from occurring in the first place. That's good primary prevention, absolutely.
No smoking.
That's a really good one. Yeah, so again, that's a good behavioral intervention, right? So we're trying to prevent people from getting from all the health effects from smoking by preventing them from smoking in the first place. So smoking cessation campaigns. You guys ever go through the DARE program at school? Yeah. I don't remember what the acronym is, but basically don't do drugs. Drugs are bad. How effective was that? Who knows, right? I'm sure there's probably some studies out there to look at the cost of that. I don't think it was super effective, but that would be a case of primary prevention in order to help prevent them from being exposed to the drugs in the first place. We do a lot of primary prevention in the poison center world. We do a lot of health fairs with the lay public and whatnot to help them learn how to poison proof their house, even though you can't really do that. You can try to make it poison resistant, but kids get into stuff apparently. So that's where we do things like hand out locks for cabinets and teach them to put things away in high spots where kids can't reach them, things like that. So then you can latent stage of disease where you have the process has started, but the patients are still asymptomatic. So this is where you can have secondary prevention. So screening and appropriate treatment may help prevent progression to symptomatic disease, right? So they already have it, but they're not symptomatic yet. So how can we prevent it from kind of progressing further? Can you guys think of any secondary prevention measures? Any infectious?
HIV.
Okay, good. So HIV. So back in the day, we see that there has been a trend towards treating patients with HIV at higher and higher CD4 cell counts, right? Because we know as their CD4 cell count gets lower, we know they're more susceptible to disease and other complications of AIDS. And so you saw over time that patients who were diagnosed with HIV, as we treated them at higher and higher CD4 cell count levels, we saw a progression of disease being prevented, right? Remember, we looked at a study where they were looking at AZT or zidovudine and patients who were asymptomatic and seeing which patients actually progressed in their disease, versus placebo, and found that AZT prevented that. So it's a great example of secondary prevention. Patients with asymptomatic TB would be another good example as well. And then you have the symptomatic stage where the disease manifestations are already evident, and this is where tertiary prevention comes into play, where the intervention may be slow, arrest, or reverse the progression of disease. But again, in this case, your patient already has it. So a lot of our drugs that we use, a lot of different things that we're using to already treat the patient with the disease that's already occurring. So we'll look at mechanism and causes for disease. So you can see where there's a biological mechanism that can sometimes be spurred on by social and environmental mechanisms as well. So in this case, they were looking at osteomalacia that was occurring due to this practice of purdah of the Muslim faith. Does anyone know what that is? So cursory understanding of it is basically, where they wear a lot of the covering, so like, burqas and things like that. Obviously, they're probably not getting a whole lot of sun exposure in those cases. So what they were seeing was that a lot of these women are having significant vitamin D deficiencies due to lack of sun exposure, right? So you can see where kind of the social and spiritual beliefs are affecting the biological mechanisms here. And what they're actually seeing was an increase in the rate of maternal and fetal mortality due to distortions in the pelvis due to this osteomalacia that was happening. So you can see where they can kind of set each other off in an example and cause, a patient population to be more at risk. We see atherogenesis being a very prevalent thing here in the U.S. So looking at things like excessive fat intake, smoking, a lack of exercise being social factors that are influencing the disease state. We see that the contribution of these social factors to the biological mechanisms being things like elevated LDL, VLDL, and low levels of HDL. So again, people's kind of behavioral factors influencing their disease progression. So again, this can be different depending on looking at things like genetic patterns of individuals. We can also see how their genes can interact with the environment and other risk factors. So obviously certain populations may be more at risk or less at risk based on certain factors for different diseases. So looking at hosts, agents, and environment, so we can see that this is kind of the triad of factors that will lead us to a disease being caused. The fourth factor is going to be the vector. So this is a very good example of this in malaria, where you can see that the host is going to be people, right? This is going to be the thing that's carrying the disease. Now we'll have the agent, in this case would be Plasmodium, which is being spread by the vector. In this case, it would be the Anopheles mosquito. And then you look at your environment. So where is this more likely to be occurring? You can see things like tropical climates, stagnant water, places like that. You see there's a very good interplay between all these factors here that allow for the disease to occur, and say specifically maybe in some agents or some populations or some environments versus others that were maybe are less hospitable to the disease, whatever it happens to be. You can see there's a big interplay here. So looking at host factors, these are going to be the ones that are responsible for the degree to which the individual is able to adapt to the stressors produced by the agent. So there's this idea of host resistance that can be influenced by a person's genotype. So certainly looking at things like skin color, if you have darker skin, you're less likely to get sunburn. Looking at BMI being a big factor that makes you susceptible to many types of diseases. Looking at your immune system, so if you have certain resistances to cancer based on different receptor subtypes you may be expressing, or maybe less likely to develop certain microbial diseases. And then also looking at social behaviors as well. Obviously, we know that exercise is going to help enhance resistance to many types of disease states. I remember one of the studies we looked at in the bio section. They were looking at more exercise in those women, how it affected their risk for cardiovascular disease. You can see that being bared out when you adjust it for all the other kind of confounding variables there. So in this case, if you're looking at measles, we see that it's seldom fatal in well-nourished individuals, even if you didn't have any immunization to it previously. But for those that are starving or protein malnourished, you see end up being a 25% mortality, right? So based on their environment and based on the host resistances, they're more susceptible to death from measles. So looking at different agents of disease, so we can see that lots of different things can fall into this category. So looking at biological agents, so we can see allergens, infectious organisms, biological toxins, foods, chemical agents like chemical toxins and dust. Physical agents, you can have radiation, heat, cold, noise. There's lots of occupational epidemiology that happens where they look at patients in industrial type settings. They'll look at things like noise pollution, air pollution over time, how that affects patients in the long run. And then also looking at things like social and psychological stressors. So, can they be agents of disease? There's probably going to be more and more studies that come out to say, yes, this probably is going to be a factor for susceptibility to certain types of disease potentially. So again, when we're looking at especially things from the poison center world, oftentimes looking for, when we have cases where multiple people are being coming down with the same symptoms, we're kind of having to track back and see, like, okay, what in the heck was going on to cause this in the first place, right? And so very frequently when we're having mass casualty incident training, very frequently we have to kind of look back to see, okay, we have all these patients who are showing up sick. What were they all exposed to? What was the common thread here? So, if it's a tanker that spilled over, releasing chlorine gas, or whatever it happens to be, there's one really good example where trying to track back the cause of it led to a very different diagnosis than what we would have normally thought. So I don't know if you guys ever heard of this case, but there was a couple of cases where patients were found in like a McDonald's bathroom, basically dead, right? And no apparent cause for it. They just walked in and the patient was dead. And you couldn't figure out what it was. And apparently the patient had died of asphyxiation. So they're saying, okay, well, what's going on here? Why did the patient end up, succumbing to this, even though it looks like there was no cause for asphyxiation in that first case? And then being able to track it back to saying, oh, actually there were CO2 lines for like the sodas and stuff that were leaking into the bathroom, leading to lower levels of oxygen, leading to asphyxiation, right? So again, a lot of it's very much like playing kind of the detective game to figure out, okay, this person has disease, let's track it back to see what the cause was in the first place. And you very much will see that in different disease outbreaks that are occurring. That's where the CDC comes in and gets involved in a lot of cases. You have disease outbreaks that are very unusual. They'll kind of go in and look for the factors that kind of led to that in the first place. So then other environmental factors can influence the probability and circumstances of contact between the host and the agent. So obviously poor restaurant sanitation can be a big problem. One of my favorite Chinese buffets in Jacksonville got closed down years ago because of so many different health violations and standing water and rat feces and stuff. I never got sick though, so I don't see why the big deal was. But maybe my susceptibility patterns were such that I did not get diseased. Lots of other people could have caught all sorts of things. Looking at poor weather and road conditions, crowded living environments can certainly influence the spread of disease very significantly as well. So we'll look at the vectors. These could be something as kind of obvious as animals, arthropods, insects, things like that. But you could also consider groups of human beings. So imagine if you're looking at spread of things like HIV, hepatitis C, things like that, and looking at patients who are IV drug abusers, right? So here, in this case, the vector could be potentially the drug dealers that are spreading around either contaminated drugs, or if you were having used needles being shared, things like that could potentially be the vector for disease in that case. So the key thing here, though, is that to be an effective transmitter of disease, the vector has to have some sort of specific relationship to the agent, the environment, and the host, right? A really good example of this, specifically with IV drug abusers, there's a case up in, I think it was either Toronto or Vancouver. It might have been Vancouver, where basically there was this kind of inner city area where they were just seeing huge amounts of drug overdose deaths. They were seeing huge amounts of transmittable diseases that they thought were being linked to IV drug abusers, basically sharing needles and having contaminated drugs and things like that. And so one of the things they wanted to do is to influence that. They ended up initiating this program where they had direct observation clinics, essentially, where patients would walk in with their drugs, they would get a fresh set of needles and all the things they needed to use the drugs, and they would do them in the spot where they could be observed by a nurse. And there was like a doctor on call that could respond if there's an overdose. There's like a chill out room they can go into, and then they had like rehab services like up on the second floor that patients could go to if they decided they wanted to do that. And so what they saw is that even though some people said, well, you're enabling them to do drugs, this is a bad thing, they were to find significant decreases in death, especially if you looked at just on the map, you looked in that specific area where those clinics were, you saw dramatic decreases in death, incidents of HIV, Hep C being spread, things like that. So overall, it was a positive for that population because they were you were able to directly influence the spread of disease in that case. So something to think about.
Keeps the market viable.
Sure, keeps the market viable. Yeah, but it's actually interesting because they saw an increase in the number of patients who were reaching out to these rehab services. They had things where they'd like find job placements for them and halfway houses and things like that. So if you Google it, I don't remember what the name of the study was itself, but if you just Google like Vancouver direct observation drug use, I'm sure you'll find the video, and it's very, very interesting if you get a chance to watch that. Nowadays, we're having more talks about using, and sorry, I keep going back to drug overdose and things like that, but that's just my wheelhouse. But one of the things they're also looking at nowadays is to use more prescribing known drug abusers naloxone. Not for themselves to use on themselves, because obviously if you're overdosing on your opiate of choice, you're not going to be able to administer that. But training people around them in order to administer it, right? So either using intranasal naloxone in order to help reverse the overdose, whatever it happens to be. They have naloxone auto injectors now, kind of like an EpiPen where you just kind of jam it into their thigh and they'll have the drug administered. So again, one of those things where it's like, well, are you enabling disease or are you ultimately preventing deaths from occurring? And so it's kind of a double-edged sword from that standpoint. So just a good example of how malaria is going to be spreading. Notice here how the vector is being the mosquito, who will introduce the plasmodium into the host, and then where the host can then eventually spread it around to other people as well when the mosquito comes back by, drains the blood, gets a plasmodium in it, and it can spread it further. So we're going to be looking at the major categories for risk factors for disease, and so this is the mnemonic beings that you can use for this. And so we're going to talk about these in detail as we move forward. So the first ones are going to be these biological and behavioral factors. So we know that risk for disease may be influenced by gender, age, weight, bone density, lifestyle, all these different biological factors that can come into it. As an example of behavioral smoking is a very good one. We know that it can increase your risk for diseases like myocardial infarction, lung, esophageal, nasopharyngeal cancer, COPD, and that we expect that cigarettes are responsible for about 50%, or at least present in 50% of MI cases and 90% of lung cancer, right? So we know it's a very, very significant behavioral component to a lot of these disease states occurring. And then obesity as well, it's been debated how many deaths are kind of attributable to obesity, but we estimate anywhere between 112 to 400,000 deaths per year related to some of the kind of the secondary effects of that. And so we see that it also may be one of the leading causes of premature death in the U.S. We can see multiple behavioral factors can lead to spread of disease, injury, and premature death. So for instance, looking at the spread of HIV and AIDS, we know that issues of sexual promiscuity or unprotected high-risk activities can lead to spread of this. IV drug abuse can be an important one. Looking at excessive intake of alcohol, obviously being linked with things like pancreatitis, cirrhosis. Drug abuse, obviously overdose is going to be one of the big things we're worried about there. Driving while impaired, homicide, suicide can all be linked back in some degree to some of these behavioral factors. And then just noticing how that changes in behavior could prevent untoward programs, or untoward outcomes. So in the case of things like HIV/AIDS, what are some things we could do to help prevent disease spread in that situation? What kind of behavioral changes could we make? Yep, it's good. So you have free health clinics and stuff like that. They'll hand out free condoms and things like that to help decrease those high risk behaviors. Right? Anything else?
Clean needles.
You have clean needles. So you have needle exchange programs and whatnot. So those could be good examples. Obviously, drug abuse, we kind of mentioned a few of those behavioral examples. We can potentially give them the antidote beforehand. You could also do kind of primary prevention strategies like DARE and things like that we mentioned before. So again, all of it has relating back to the behavior of the patient being the strongest factor associated with that. And so you'll see that many efforts in health promotion depend heavily on modification of human behavior, because one is probably one of the cheaper things you can do, especially if it's just like education campaign or things like that. and it could potentially have one of the most kind of the biggest effects. If you can change the behavior of the person, you can, in some cases, really limit the occurrence of that disease to occur in the first place. So again, especially with DWIs, see all those driving drunk campaigns and things like that to help try to prevent them from occurring. So looking at environmental factors, so epidemiologists are oftentimes going to be kind of the first professionals to respond to an apparent outbreak of new health problems. So very frequently, we did some work with the Georgia Poison Center, and you guys know that the CDC is based out of Atlanta, especially if you watch like The Walking Dead or something. But they oftentimes get kind of roped into a lot of those initial outbreaks. So if they hear there's cases of stuff that are occurring in kind of unusual incidences, then they will send out an investigatory team to go find out what's going on there. And so one case of this would be 1976. They had the American Legion Conference in Philadelphia. They had this kind of epidemic of pneumonia that was occurring in all these attendees to the conference. And so what they're actually able to find was that the infectious agent in the air conditioning system of the primary hotels that all the Legionnaires are staying at, and they found that Legionella pneumophila was the big thing here. So they were found to be thriving in the air conditioning, cooling towers, and the warm water systems, and that's where we get Legionnaire's disease from, essentially. Then looking at Lyme disease, back in 1975, the first report of an illness with an organism transmitted by a tick was reported. And then since then, we've been able to kind of link it back to the spread through these ticks. That's where Lyme disease comes from. We can look at immunologic factors, so we'll talk more about smallpox. We know this is to be one of the first infectious diseases to be eradicated from the globe. That's why it's also a potential agent for biological terrorism, because it could be so devastating, because again, essentially we think it's all kind of wiped out. Not a lot of people get vaccinated against it anymore. But basically the reason why we're able to eradicate it was due to this massive vaccination campaign that was done basically across the world to help influence individual and then herd immunity. And what is herd immunity?
You can vaccinate the majority of the people, then those that aren't vaccinated still reap the benefits.
Yeah, so if I vaccinate half you guys against the disease state and the other half you guys did not get anything, your rates would be reduced because of the fact that these guys are not able to carry and pass on the disease to the unvaccinated individuals. We'll talk more about that a little bit later on. And then looking at immunodeficiency, so this can be affected by several things. Certainly disease can affect it, genetics, malnourishment, chemotherapy, and corticosteroids all can decrease your immune system and make you more susceptible to developing certain diseases. Certainly we can see certain nutritional factors. So an example is back in the 1950s, they were looking at Japanese Americans who were living in Hawaii and saw they had a much higher rate of MI than people of the same age and sex in Japan. And so in California, they saw that the rates in these individuals was even higher still. And so what they ended up determining was that Americans have pretty bad diets, right? Dietary factors were determined to be the cause of the differing disease rates. As you might imagine, their diets changed pretty significantly from Japan over to the US. Obviously, they had lots of fried foods and all kinds of good stuff. Anywhere you can get a fried Twinkie, probably not going to be good for your health, right? So essentially, the other things that we're looking at is also the role of dietary fiber on good health. And as you might imagine, here in the U.S., you think we probably have a higher fiber intake or lower? Mm-hmm. Probably a lot lower, right? So it's kind of interesting some of his musings he came across when looking at fiber intake and looking at health across the world, basically by saying that the entire U.S. is constipated for the most part. I'll never forget my cousin, he had a young daughter who's probably 3 or 4, and said, I'm taking her to the ER. I don't know what's wrong with her. She's having the worst abdominal pain ever. And I go, she's constipated. And he's like, how do you know? I don't think so. She says she's dying. And I'm like, she's constipated. Sure enough, an enema later, she was right as rain. Very, very common. But they were showing that, you really don't diagnose appendicitis in Africa unless the patient speaks English. Kind of showing back to those kind of dietary habits there. African medical students go through 5 years of training without ever seeing coronary heart disease or appendicitis. And populations with large stools have small hospitals. Those with small stools have large hospitals. So that was kind of an interesting observation. So eat your fiber is basically the lesson there. It's good to take with your breakfast, before you come into class. Anyway, so diseases that have been rare in the indigenous populations of tropical Africa, some of the things I think might be linked back to certainly genetic factors, but could be other dietary factors as well. Appendicitis, coronary heart disease, diabetes, hemorrhoids, gallstones, all these different things that tend to be more prevalent here in the U.S., which again could be related to our diet. So, the differences in the incidence of these diseases were not primarily genetic in origin in these cases, because they look at African Americans in the U.S., right, who should have very similar genetics to those they were looking at in Africa, and they saw that their rates were very, very similar to others there in the U.S. So again, the heavy burden of these diseases is thought to not really be inevitable. You guys remember this SNL commercial back in the day? Yeah. All right, so some other genetic factors that can be involved here. So certainly inheritance of individuals interacts with their diet and their environmental factors in very complex ways. This is why in a lot of cases you're trying to control for a lot of these variables to make sure that you're not having a lot of confounding when you're looking for some of these links in these disease states. So population genetics and their genetic epidemiology are concerned with the distribution of normal and abnormal genes in the population and whether or not these are going to be in equilibrium. So, is there maybe some sort of environmental factor that's causing abnormal genes to be popping up? Say if there's some kind of pollution issue or something like that. And so we see that genetic epidemiology is more concerned with gene mutation rates, in which typically should not be changing. They should be kind of happening on a certain scale, but they look to see if there's any kind of new change in that. And now we know that genetic disease is accounting for a higher proportion of disease than in the past, not necessarily because the incidence is really increasing, but because we are able to, we're seeing that the incidence of non-inherited disease is decreasing, right? So the rates are staying pretty much the same, but we're seeing other things, rates that are decreasing to make this one more prevalent. So for instance, we're looking at rickets, which can be a genetic disease, recently showed an abrupt fall in incidence and an increase in heritability in Quebec. Basically, they saw that the fall in incidence was followed by universal supplementation of dietary dairy milk with calciferol. Right? So basically they're adding extra vitamin D to their dietary milk and saw that the case of nutritional rickets was decreasing very dramatically, and now you saw more of the patients who were having the genetic causes for it being more prevalent, right? It's not necessarily that the incidence was changing at all, it's just the fact that they happen to be, the ones that you do see, it's going to be more related to those genetic factors. So you can see how things like that, how simple nutritional changes can kind of make these, kind of take the spotlight a little bit more. And then looking at services, social and spiritual factors, we can see that medical care services may be quite beneficial to health, but they can also be potentially dangerous. So if you imagine, medical errors within the hospital is a huge issue. We also know that things like nosocomial infections are a big issue as well. I always say that the worst place to get healthy is in the hospital, because you're more likely to catch something, or we talk about things like having the wrong limb being operated on, or getting the wrong medication. All kinds of different things can happen incorrectly in the hospital. And so again, when you have better access to healthcare, you're going to see an increased incidence of some of these medical errors are popping up because of that, right? So it's kind of a double-edged sword to some degree. We can see the social and spiritual factors. We kind of mentioned that previously when we talked about that practice of PERDA leading to osteomalacia due to vitamin D deficiency. We see that in some cases, though, actually having better kind of spiritual well-being tends to increase health in certain patient populations. So there may be some data out there to show that even if you just have a strong religious faith, you may have better quality of life, better perceived better health for those patients due to that. So again, you can see many different interactions here, even for things you may not think will have a direct impact on a patient's health. One of the things they were also looking at, they're looking at health outcomes in some of these in relation to some of these spiritual factors. So they're looking at Mormons and Seventh-day Adventists, and so what they were seeing is that these groups tend to have lower than average age-adjusted death rates for many common types of disease. And so when I say age-adjusted death rates, what does that mean? What do you think that means? Basically, you're taking age out of the consideration, right? Because obviously older patients are more likely to die just in general. But when you do age-adjusted, basically you're kind of taking that confounder away from there to look just to see, what are their risks for, different outcomes, different causes of death without having to worry about age being a confounder. So specifically, they're seeing decreased rates in these populations from heart disease, cancer, and respiratory disorders. And so some of the things that we're kind of postulating here is that while Mormons, they prohibit the use of alcohol and tobacco, so maybe you'll see less incidence of that in those patients. And then Seventh-day Adventists likewise tend to avoid alcohol and tobacco, and they usually encourage having a vegetarian diet, right? So all those things, changing the behaviors of the patients, may lead them to be less susceptible to some of those outcomes. You guys ever been to the Florida hospital cafeteria? I've heard about it. I've never been to it personally, but is it? Yeah, it's good. One of my friends worked there for a short time, and so she was telling me about how they have the regular cafeteria and then they have the secular cafeteria. The regular one is nice and brightly lit and big windows and all the food's really nice, and then they have the secular cafeteria have like kind of blinking lights and it's really kind of dingy, and that's if you want your soda, if you want your fried food, that's where you go to get it. So I thought was kind of interesting. But again, seeing how these behavioral changes based on spiritual factors can influence disease rates. They also get off early on Fridays, which is kind of cool, right? It's usually a good thing. No. So looking at ecological issues in epidemiology, so classical epidemiologists have long seen their field as human ecology, medical ecology, or geographic medicine, because we know that from the ecologic perspective, this can have huge impacts on spread of disease. And so not only are we just individual organisms, but also members of these kind of social communities that inhabit these environments. And so you really need to understand it's kind of a complex ecosystem and where these disease patterns can vary greatly from one country to another based on all these different factors we've kind of been mentioning already. So looking at growth in the world population, as of August, there's about 7.4 billion people in the world. And with the recent developments of technology, it can have profound impact on the global environment. So in a lot of cases, you can see kind of deleterious effects in the most part. So again, you can see a lot of biodiversity helps provide the planet with greater adaptive capacity, but now it's kind of threatened because we're kind of overpopulating to a big degree. And so that every action that we see that can affect the ecosystem, even though it may be a positive effect on the health of the people living within it, could produce kind of a negative reaction down the road. I'll show you some examples of these in just a minute. So, for instance, if we were looking at childhood infections, and we see here where, if we're having these infections, how can we prevent that? Well, we can give vaccinations, okay? And some of the unintended consequences of that. Maybe we can see decreased level of immunity during adulthood. I'll show you some examples of that later. But that could be related to, decreased risk of, repeated exposures to that infection. So we don't really receive any natural boosters to our immunity as we become adults. Looking at things like human infant mortality rates. As we get better sanitation and infant mortality rates go down, you worry about increased population boom, right? You worry about overpopulation of the world. We'll talk some more about these examples a little bit later, but just realize that every change we're making here could have potential outcomes which may be positive or negative down the road. Because I'm very anti-vaccine. I'm just kidding. Me and my wife were just like, how soon can we get the baby vaccines? They're like, she's 2 days old. Just give her anything you got. Okay, so one of the things we'll talk about is vaccination and patterns of immunity, especially within populations. And so understanding herd immunity is kind of essential to thinking about the ecologic problems with immunization today. So basically, if there's no herd immunity against disease and everyone is susceptible, then the number of cases should really double with every disease generation. Or as that person gets the disease, they can spread it potentially to 2 people, and they can spread it to 2 people, and they tell 2 friends, and they tell 2 friends. Eventually, you're spreading the disease even further with every generation of it, so to speak. Basically, if you look at the model, if there's 50% herd immunity against the disease, the number of cases typically is going to remain small and remain approximately constant. I'll show you a picture of that in the next slide. So essentially in this model, if there's greater than 50% herd immunity, as would be true in the well-immunized population, the infection should die out eventually, right? Because eventually there's just no one else who's really susceptible, no one to really give it to that next person. So if you're looking here at this slide, let's see if I can use the laser pointer for video purposes. So in the absence of herd immunity, say we had the first person here who gets the disease, so they're the initial case, and they could potentially spread it to 2 people, right? Because no one basically has protection in that population because there's no herd immunity, right? So everyone is susceptible to it at this case, and then they can keep spreading it further and further, and you just see the disease continuing to double with each generation. On the other hand, if you're looking at the say 50% presence of herd immunity, so only half the people should have it. If you're looking at the initial case, looking at it, they would have one person who is not susceptible to the disease, so they would not contract it, and then you have one person that could get it. Okay. Going down to the next generation, again, 50% of the people have innate immunity due to vaccination. So you can see this person wouldn't get the disease, and this person wouldn't either. And because this person would never have been exposed to it, they remain negative. Whereas this one person here, you can see only 25% of the population would end up getting in that next generation. Going even further, you can see how the numbers remain relatively constant as you have 50% being just innately immune to it, but those other people have never been exposed to it because, again, they never had contact with it. So again, how herd immunity can, even 50% can keep the disease rates relatively low. So the degree of immunity necessary to eliminate a virus from a population is going to depend on several factors. So when it looks at the type of virus, looks at the time of year, and then the density and social patterns of the population. So for instance, if you're looking at the flu vaccine, how come you have to get a flu vaccine every single year? Yeah, so different strains we're actually protecting against. And so, you'll hear about trivalent and quadrivalent vaccines. What do you think that means? Not how many doses you need to get. How many strands are you protected against, right? So typically they're going to, people will look at the predicted strands that will be, prevalent during the next flu season, and they'll develop a vaccine against either 3 or 4 of those strands. And again, since the swine flu is kind of a bigger deal, that's where the quadrivalent, or the ones that will protect against 4 strains, kind of came from. Again, some years you'll find that flu is going to be much more common because they mispredicted which strain would be most common, and then you'll have a bunch of people coming in saying, well, I got the vaccine and I still got the flu. Right, it's not 100% going to protect you from it. It's just very likely to provide that immunity. Again, looking at the time of year, obviously with it being colder out there, we can expect, certainly big increases in things like influenza, RSV is going to become big. This is where, you get the busiest times, especially in the PDR, all kinds of upper respiratory tract infections. And then, it may seem that immunization is simple. Just immunize everyone in childhood, and there'll be no problems from the targeted disease. But we realize that the control of diseases by immunization is a little bit more complex than that. So one thing we'll talk about is diphtheria here. So the vaccine produced immunity in individuals that tended to decrease over time. So basically we'll see that there are different variations in the durability of vaccines. We'll talk more about that in Pharm 2. But essentially there's different types of vaccines. Some will remain constant. Some you'll end up losing immunity over time. It just depends on the type of vaccine it is. So when diphtheria was a more common disease, people who had been exposed, or people who had been vaccinated against it, were exposed more frequently to the causative agent. And so this meant that exposure could result in a mild reinfection. And basically you have this natural booster effect where you kind of boost up your immune system and you remain immune to it over time because you've been exposed to it over and over again, right? So similar to how you get like a tetanus booster, same thing is happening here. So as diphtheria became less common because of the immunization programs, you found that fewer people were being exposed, and thus there were a lot fewer of these subclinical booster infections that were happening here. So in this instance, they were looking at Russia. They found that despite the wide availability of diphtheria vaccine, many adults who had not been recently, or had not recently been in the military, were found to be susceptible to the diphtheria organism. Right. So again, usually in the military, you find that's one place where you can have certain spread of disease because you have a lot of close quarters of people kind of being herded together. And then when you saw in 1990, major epidemic of diphtheria appeared in Russia. And then by 1992, about 72% of the reported cases were found to be among individuals older than 14 years of age. So that kind of makes sense. So again, less exposure over time, less of that booster phenomenon. You have more adults that are going to be susceptible to the disease. In which what is frequently given along with the tetanus vaccine? Yeah, tetanus diphtheria. So usually see TD is a very frequent your tetanus booster. Yeah, Tdap would be the other one. What's the AP for?
Acellular.
Yeah, so that's the only one you get that exposure to. So this was not due to a lack of initial immunization. Again, more than 90% of the adults in Russia had been fully immunized as children. It's just that the disease in older people apparently was due to that decline in the adult immunity levels. And then before they were able to get the basically the epidemic under control, 125,000 cases of diphtheria and 4,000 deaths had occurred. So pretty significant. Smallpox is going to be another good example of how we had actual eradication of a disease from the globe. So basically the goal of worldwide eradication of smallpox has been met by immunizing people against the disease. And so there were some potential risk in the attempt to eradicate the disease, as we'll see. And essentially back in the 1970s, we saw that the dominant form was going to be this variola minor. And again, it was a relatively minor form of smallpox, often disfiguring, that had a relatively lower mortality rate versus the variola major. So we found that individual and herd immunity against the much more disfiguring and often fatal variole major form of the disease, or the classical smallpox. We found that the vaccine against the variole minor was protective against both variants of it, which was good. And so to eliminate it and then instead get variole major would have been a poor exchange. But what we found was that you did get protection against both when you had the immunization. So here, looking at poliomyelitis, we see that the need for herd immunity was also shown by polio. We found that previously we were giving the killed or inactivated polio vaccine, which became available in 1955, provided protection to the immunized individual, but did not produce much herd immunity. So you can see that although it stimulated the production of blood antibodies against poliovirus, it didn't really produce that cell-mediated immunity in the intestine. And so frequently is where the poliovirus would multiply, and so it really didn't do very much to interrupt that replication in the intestine. So by giving the inactivated form, and again, if you imagine what's going to be provide a better protection with the vaccine, if you have an inactivated form of it, or say if you had a live weakened form of it. Yeah, the live attenuated form is obviously going to provide much better immunization than a killed or inactivated version of it. So what they were seeing here is they were having declining rates of paralytic poliomyelitis, and many people basically kind of were lulled into a false sense of security, and they actually saw the immunization rates for newborn children start to decrease, and they saw a kind of small epidemics of polio started to pop up in the late 1950s and early 1960s because the poliovirus was still present. Even though they had received the immunity, they were still having replication of the virus and could spread it to people who had no immunity in the first place. So you really didn't get good herd immunity in that case. And so then they came out with the attenuated oral polio vaccine that was approved in the early 1960s. So in this case, the OPV produced cell-mediated immunity, preventing poliovirus from replicating in the intestine, and provided a nice herd immunity against people who had even never received the vaccine in the first place. So after widespread use of it in the U.S., the prevalence of all three types of the wild poliovirus declined rapidly, and basically they were monitoring waste sewage and were able to determine this. Because it was in the intestine, so obviously they could do the waste sewage in order to monitor for that. So now it seems to have been eradicated from the Western Hemisphere, where the last known case cause was back in 1991 in Peru. So it might appear that the OPV might always be superior. What's kind of one of the problems with the live attenuated vaccine?
Immunocompromised patients.
What happens in immunocompromised patients?
That will actually get the disease.
It can mutate and actually cause disease.
Yeah, so it could potentially propagate and actually cause the disease you're trying to prevent in immunocompromised patients. Good point. So here when they were looking at the health department for the Gaza Strip, they only ever use the oral poliovirus in their immunization efforts. And so they end up having many cases of paralytic poliomyelitis occurring in these Arab children. So what they found was that due to inadequate sanitation, the children often had these intestinal infections where they were given the oral poliovirus, but unfortunately it interfered with the infection in the gut, and they were able to basically had the vaccine not really take. And again, yes, typically why you don't want to give vaccine to patients who are kind of actively sick, because again, it could be hard to develop immunity against that particular disease. So in this case, the children, even though they had received the vaccine, ended up being unprotected and developing the disease. So in this case, what they ended up doing was switching to an immunization program in which the children were injected first with the inactivated poliovirus to produce an adequate blood immunity for themselves, and then later on were given the oral poliovirus as a booster vaccine, and that way you still attain the herd immunity. So by using both versions, one, you can protect the children who are more at risk for developing the disease, and then you develop the herd immunity later on, and when you give that kind of booster effect. And so you see here the rates of actually developing paralytic poliomyelitis from the oral vaccine is 1 case per 2.4 million doses, but by giving the inactivated form first, you end up preventing that from occurring in the first place. Okay, so we can also look at the effects of sanitation, how that can have an effect on disease spread. In the 19th century, we're looking at diarrheal diseases were usually the biggest killer of children, and we saw that TB was the largest killer of adults. Again, a long time ago, back before sanitation was really good. What they ended up finding in England, when they had the sanitation, revolution, again, part of that, the cholera and all that we saw by, removing, contaminated water pumps and other measures like that, we ended up finding that this is one of the most important factors in ended up reducing the infant mortality rate. So just better sanitation led to this. And so what they ended up seeing is that reduction in infant mortality contributed basically to increasing the effective birth rate and the rate of population growth. Because again, you have less children dying, so more of them surviving to adulthood, population is going to go up. And again, this could be one of the reasons why we have the worldwide population issue that we're having nowadays is due to decreases in infant mortality. So basically, you can end up developing these demographic gaps where you're having some sort of change in the environment lead to increased number of survival of children into adulthood, leading to these kind of rapid population growth cycles. You guys ever seen The Meaning of Life with Monty Python? Wow, you guys need to catch up on that. Essentially, this is there's a scene back in England back during this time period where basically there's a Catholic family, and so every child was very sacred to them because again, so many of them were going to die, so they ended up having like 50 kids running around the house at one point. It's a good movie, you should check it out. But essentially, we see that to accept population control, you see that the control of infant mortality seems to be very necessary for that. So when the infant mortality rate is high, family needs to have large numbers of children in order to make sure that you at least have reasonable confidence that one or two will achieve adulthood. And then reductions in infant mortality rate seems to have a cause of population problem and requirement for population control, right? That's why some countries have instituted bans on how many children you can have and things like that as a means to control population growth. So again, we can see where disease patterns will be affected in unanticipated ways due to sanitation. Improvement in sanitation also was a fundamental cause for the appearance of epidemic paralytic poliomyelitis in the 19th century. So again, before the vaccine was introduced, the epidemics of paralytic poliomyelitis tended to occur as the nation's sanitation improved, right? Because we mentioned they were growing the virus would grow in the gut. And through improved sanitation, reduced the proportion of patients who were infected with it. It also delayed the time where most infants and children were being exposed to it, right? So the kids who ended up dying from things earlier on, now they have kind of a longer time before they're being exposed to these viruses. So then most children were being exposed after they were no longer protected by maternal immunity, because we know that when you're breastfeeding and things like that, mom's passing on lots of antibodies to the baby. So because they were kind of past that point where they were receiving any of that maternal immunity, they ended up having a higher percentage of those children actually developing the paralytic form of the disease. And so, again, unintended effect, seeing this increased risk of polio. And oftentimes, because members of the upper kind of socioeconomic classes had the best sanitation, they were oftentimes hit the hardest with it until we had the introduction of the polio vaccine. So we can also look at things like vector control and land use patterns that can affect disease progression. We can see that in sub-Saharan Africa, it's kind of a disturbing example of how the negative side effects can come from an attempt to do some good. And so in this case, there was a successful effort to control the tsetse fly, which was a vector for carrying this African sleeping sickness in cattle. Sometimes it can be spread to humans as well. And so one of the things they're able to do is control that vector, control the fly, the populations of it, and then now they're having larger numbers of cattle because they weren't dying to this. It led to overgrazing, and that was leading to frequent droughts, and some places even became dust bowls because of this, right? More cattle, there's also, issues with, climate control and things like that, especially as they're producing more methane, can degrade the ozone layer over time. So just doing this thing to increase the population of cattle ended up kind of having devastating effects to the environment. So, contributions of epidemiologists to the medical science. Basically what they're doing is to provide initial hypotheses about the disease causation for other scientists to really test in the laboratory, right? So they kind of come up with their initial ideas of what's going on, and then other people can kind of carry out further study. So in the past 30 years, we can see the epidemiologic methods have suggested the probable type of agent and modes of transmission for many types of diseases. And so basically knowledge of the modes of transmission allow for that prevention. Right, so again, if we know what's going on, if we know if it's a behavioral issue, if we know it's a genetic issue, we can hopefully help prevent that from spreading because of that knowledge. Laboratory work to identify causal agents. We can also work to clarify the pathogenesis, develop vaccines or treatments for many diseases. Many years after the basic epidemiologic work is done, right? So oftentimes it's going to be kind of long-term work that's being carried out in order to help prevent that disease, especially when it's something specific like a vaccine that has to be made for that. The rapid growth in population, increased travel, contact with new areas such as jungles and declining effectiveness of antibiotics and insecticides are also encouraging the development of new diseases or the resurgence of older ones. So certainly we see increased risk for really drug-resistant antibiotic or drug-resistant bacteria, especially extended spectrum beta-lactamase producing gram-negative rods and things like that. Certainly go in any ICU and you'll find that. But again, a lot of it's due to these new interventions we have, like newer antibiotics. So, and then global climate change can also maybe extending the range of some diseases and help create other new ones. So we may see changes due to increasing temperatures worldwide. So again, just some examples of different diseases that have been investigated by medical epidemiologists and kind of the methods for prevention. Even something as simple for Lyme disease, just avoid ticks, right? But unless you knew that tick was causing that disease in the first place, you wouldn't have known to avoid them. You can look at things like, acquired immunodeficiency syndrome or AIDS, looking at things like how to prevent it, like, using protection, avoiding kind of high-risk behaviors, avoiding used needles, things like that. Notice how a lot of these are all behavioral changes we're making here, because those are oftentimes the easiest ones and can very frequently have the biggest impact, especially for the early prevention. So, again, when we're looking at these first identified cases of a new disease, oftentimes they can be fatal or severe, which again, that's typical. It's kind of tipping people off in the first place. If it's a very kind of minor thing, it might not really ping off on anyone's radar. We call this kind of the iceberg effect. Because as we know more about the disease, we realize that there probably are a lot more people who are less severe or even asymptomatic than what we initially discovered. So with infectious diseases, even asymptomatic infection may be uncovered either by finding elevated antibody titers, that's one way you can look for it, to the organism in clinically well people, or by culturing the organism from them directly. And so the variation in severity of a disease process based on that spectrum of disease is, again, the iceberg phenomenon. So imagine if you were investigating, a new case of a rash of deaths that were kind of mysterious, and you go and check it out. You realize that there's 2 deaths that have occurred, 12 people with clinical illness. You realize that there may be a significant number of asymptomatic patients that may be at risk, and so your goal is to really determine kind of what the mode is there, and try to see how you can identify those at-risk people to hopefully prevent the disease from spreading further. So again, randomized trials of preventative measures in the field, oftentimes called field trials, are an important phase for evaluating new vaccines before it's given to a community at large. So this is some of the trials they'll perform in order to see how effective the vaccine is. And then after introduction of the vaccine, you have to do ongoing surveillance of the disease and look for vaccine side effects as well. So again, that's why the vaccine adverse effect reporting system is there, the VAERS system. That's why it's very important that anytime there's a new adverse effect seen, or say the disease occurs in someone who's received the vaccine, it needs to be reported. So that way they can kind of follow that to determine, maybe the vaccine's bad. Maybe they need to go back and there's a new adverse effect they weren't expecting based on the smaller number of people they gave it to. So for instance, good example of this is there was a large-scale field trial for the Salk IPV. Basically, it was the variety of the vaccine they were using. It was done. It was confirmed that the value and the safety of the vaccine, so they wanted to go ahead and start using it. And then in 1955, the surveillance system of the CDC discovered an outbreak of vaccine-associated poliomyelitis, and they actually linked it back to a specific producer of the vaccine, this Cutter Laboratories. And so basically, they were doing a slight change in the recommended procedure for producing the vaccine, and that ended up causing the clumping of the virus and leading to live virus actually being injected into the patients. So you can see here where that reporting is really necessary, because otherwise you have these kind of unrecognized cases going. And so, again, it's only because of that surveillance that we were able to quickly detect it and be able to remove the dangerous vaccine from the market. We have lots of ongoing surveillance programs that are responsible for detecting things like outbreaks of measles in various cases. And then the epidemiologists were able to show that much of the unexpected disease occurred in college students and others who had received the measles vaccine before 12 months of age without any later booster doses. And so because of those findings, they're seeing that the timing of the vaccine mattered, because if it was given while maternal antibodies were present against measles, you saw that the ability to produce kind of a sustained response against measles was reduced, right? Because the kid already had antibodies to fight off that measles. So now that's where we get the current recommendations to give measles vaccines, initially at 15 months. So hopefully it's past that time where any maternal antibodies are left over, and then to give a booster dose before primary school, and to ensure that the students have had at least 2 doses of measles vaccine before graduating from high school. That way, they've kind of had a sustained effect from it. They've gotten their boosters, should have sustained immunity against that. And nowadays, the epidemiologists are contributing to Homeland Security by helping establish new approaches for surveillance. So they do this thing called syndromic surveillance that identify changes in disease occurrence, but also looking for potentially suspicious symptom patterns, right? So especially with anthrax scares and things like that, they can start to look for these outbreaks before they're actually really clinically evident cases. So how do we set the disease control priorities? Basically, it should be based not only on the currently existing size of the problem, but also on the potential of the disease to spread to others. So again, how virulent the disease truly is. Its likelihood of causing death and disability. Obviously, you want to focus on the ones that are going to be more devastating. And then the cost for the individuals, families, and the communities. And so we see that oftentimes the legislature will fund disease control efforts inappropriately, and then only doing it by considering the number of cases that are reported. So usually kind of short-sighted, things that are kind of high priority items that seem like, okay, these people are dying from this, let's fund this right now. Sometimes you can kind of miss those kind of preventative steps when looking at the long run. So in this case, in the 1950s, they had a sharp drop in reported syphilis cases, which led to declining support for syphilis control in the U.S., which then contributed to kind of subsequent rebounds later on. And so you'll see that sometimes the health funding is going to be more influenced by lobbying individuals with more money, and then for research or control efforts for a particular disease or injury. So again, follow the money, you'll probably find where the funding is going there. And so based on some of the studies that we did back in the early 1980s, we saw the potential threat that AIDS posed to society was recognized as being far greater than what was suggested by the absolute number and cost involved at that time. And so a large proportion of the national resources was allocated to the study and control of AIDS than it was actually focused on to other diseases. And so again, special concerns with AIDS included rapid increase in the number of cases reported during a brief period, because again, underreporting can be a big problem when doing disease surveillance. They're also looking at the high case fatality ratios, and then the huge amount of societal and healthcare costs that were involved with treating these patients as well. And then other things like, looking at the 21st century, that smoking has declined over time. Degree of control has been achieved over AIDS. A lot of our patients are living longer, having better quality of life due to new treatments. And then basically, one of the most recently increased caloric intake and sedentary lifestyle are producing a rapid increase in overweight and obese individuals. Type 2 diabetes is increasing as a result. So you can see how our priorities are kind of shifting over time based on what the kind of the more prevalent issues are. So how do we improve diagnosis, treatment, and prognosis for a clinical disease? We see the application of these epidemiologic methods help to answer these clinical questions, help us to improve clinical medicine, especially in how we diagnose, what types of therapy we're going to initiate, and then also the prognosis of disease. And so again, how we can work to improve diagnosis, if we can select the best diagnostic test, things that are most likely to be very sensitive and specific for those diseases. Look at the best cutoff points for running diagnostic tests, like who are the most at-risk patients, and then development of strategies to use in screening for disease. So for instance, what was kind of one of the big recent virus outbreaks we were worried about? So Zika's a big one. What was the one right before that? Ebola, right? So does anyone know what we were doing at hospitals to screen for those patients?
Asking people about travel.
Yeah, specifically. So anyone that was coming into the hospital, the first question they had asked of them, have you traveled outside of the U.S. within the past whatever time frame it was, right? That way, if they answered yes, and then you can ask more targeted questions, but okay, was it to any of these specific countries? If they answered yes, then you can start to do more in-depth screening, right? Yeah, back away, put on your mask. Right, but that's kind of one of the first steps that we can do to try to help identify those patients and hopefully identify them, see if they're at risk, and if so, get them treatment early. So even something as simple as one question at the hospital can mean a big difference here. So looking at the treatment, so again, looking at one study used a randomized controlled clinical trial in many centers of the U.S. to test basically whether or not methylprednisolone would reduce spinal cord damage and improve residual motor function after acute spinal cord injury. So again, hypothesis was confirmed here. A lot of these things can end up changing gold standards of care, and so very frequently, if you have a spinal cord injury, this is one of the main drugs you're going to be getting is big doses of methylprednisolone due to studies like this. Looking at prognosis, we can see epidemiologic tests being used in a case-controlled method. We are comparing different coronary prognostic indices, analyzing their weaknesses and suggesting ways prognostication could be enhanced. Because again, a lot of times patients, families, they want to know, what's the prognosis, what's the likelihood of them, either progressing disease or whatever happens to be. And so, investigators need accurate prognoses to stratify the patients into groups with similar disease severity to research and evaluate treatment. So, you guys are familiar with a lot of these different scales and things like that. So, when we talked about specifically, we were talking about hyperlipidemia. We talked about the new guidelines, and they're looking at that risk for atherosclerotic cardiovascular disease. Remember how there was like a 10-year scale to look to see what your risk for cardiac disease was, right? Did things like age and smoking, and it was all a way of basically stratifying your patients to see what their risk was. And so a lot of these studies are aiming to do just this. And then also looking at risk estimation. Perhaps best developed in various cardiac risk estimators. We're looking at the Framingham Heart Study was one of the big ones where we get a lot of like our CHADS-2 scores and things like that. Help to identify those patients who are at biggest risk. And then looking at improving the health services research. So the principles and methods of epidemiology are used in planning and evaluating different models of medical care. And so looking at some of these, you can determine potential present and future community health needs. And so then you can look at things like demographic projection techniques and estimate the size of different age groups in the future. We can look to see our increasing our aging population as the baby boomers start to get older and things like that, and kind of estimate what the needs are going to be as we move forward. And then looking at the analysis of patterns of disease frequency, you can use services that can help estimate the services that will be needed based on that. So we see increasing risk for certain types of disease. If we're looking at things like obesity and whatnot, we know that we're going to have increased heart disease later on based on that. So again, looking at things like cost-benefit analysis, looking at epidemiologic methods, and are used to determine kind of the effects of medical care and what that'll be on in the long run. So just in summary, for this first section, we'll see that epidemiology is that branch of medical science that relates the happenings in the lives of individuals and populations and looking at the distribution of disease, injuries, and other health problems. And obviously, we're going to be looking at all the different factors of that. So both biologically, socially, behaviorally, anything that can influence disease progression or spread, we're going to be looking at it from this standpoint. So we're going to be applying, these statistical models and these scientific methods to kind of new health problems to define its incidence in the population, develop these hypotheses about the causes of it, methods of transmission, how we can hopefully prevent it from spreading in the future. And then basically we're going to be describing the causes of a disease in terms of the host, agent, environment, and sometimes adding a vector as a fourth factor for consideration, especially with infectious agents, or like we saw with the drug dealers and handing out used needles or contaminated drugs and things like that. So hopefully we're going to be able to explore the means to prevent a given disease, look for possible behavioral, genetic, or immunologic factors with that, and then if we can look at other nutritional causes, biologic causes, and then basically just remember that BEING's acronym and how those different factors will kind of go into that. We're also going to be looking at human ecology, and particularly the impact of the health interventions that we're having on future disease patterns and on the environment as well. So how the changes we're making today, while it may increase health for certain populations, how it may be affecting other populations later on. And then knowing that the solution to one problem can probably lead to other problems down the road. And then we have lots of different interventions that the epidemiologist can contribute. So whether it's investigating new diseases, studying their spectrum, coming up with new ways of prognosis or treatment, whatever happens to be, they're involved kind of in all steps of the process. So any questions on our first section? All right, so now we got kind of the basics out of the way. We'll get more into the nitty gritty on the next section, which will start up tomorrow. So if you have any questions, let me know.